Our guest speaker, Dr. Jordanna Kapeluto, completed training in internal medicine and endocrinology and metabolism at UBC, University of British Columbia. She completed an additional clinical fellowship and research postdoctorate in obesity medicine and bariatric surgery at Laval University. During her fellowship, she was awarded the Endocrine Society's Outstanding Abstract Award and its Presidential Poster Competition Award. She was also awarded the Dr. John Dupree Award for her research in diabetes and bariatric surgery. Dr. Capeluto is a clinical assistant professor at the University of British Columbia with an appointment at Vancouver General Hospital and works with the Richmond Metabolic and Bariatric Surgery Program. So I'm going to go and hand it off to Dr. Capeluto and she will present. Thank you. Yep. Got it. Dr. Capeluto.
So Trisha, sorry, I'm getting like a message that my internet's unstable and I was cutting in and out. So I don't know if you guys can hear me or not. What I might do
Yes, we
is
can
I
hear
just might,
you. It is
okay,
kind of
okay,
wavy.
choppy. Let me see if I can log on my phone, and then maybe talk to you through my phone, but I'll try to do slides.
Sounds good. Dr. Capello is at the Diabetes Canada, at the Diabetes Canada conference right now. So she is calling in from there.
Sorry, guys. I know you have me in two separate views, so let me just make this less confusing for people. Can you hear me now? Okay, perfect. Okay, so hi everyone. There's some names on there that I recognize. There are some new names. I tried. I didn't know how scientific you guys wanted me to get versus less scientific. So tell me if you want more information, less information. This is open to two-way feedback, but I'll try to sort of unpack some of the myths for you, and maybe give you a better sense of what you want to know about this therapy. So let me just set up my slides here. Um, are you able to see my slides now? Oh,
Looks good.
it looks good. Okay, and is it letting me? Just let me. Sorry, guys. Just let me get this in a more friendly format. Oh my goodness, what is going on here? Okay, are those slides nice and yeah, they're nice and big for you guys. Okay, perfect. So I was going to talk to you guys about this whole concept of GLP-1 therapy in type 1 diabetes. The title I was given was Ozempic, Wegovy, Mounjaro, the future of weight loss. So we can talk about that and we'll figure it out. So it's pretty standard when we're giving these talks, just to let you know if I have any stake in the information I'm giving you. And I, fortunately or unfortunately, do not have any stock in these very expensive medications. I also don't take any money from any pharmaceutical companies. So the information I'm giving you is based on my opinion, not influenced by anything anyone else has told me. But I do from time to time get paid by UBC to give talks like this. So those are my disclosures. And the other thing that's important to understand is that some of the information I'm going to give you is what we call off-label use of medications. So when medications are developed, they have like a specific indication or a reason that Health Canada accepts that we can use them. But some of the questions that people had and some of the medications we're talking about, like Ozempic, in certain circumstances could theoretically be considered off-label. So just keep that in mind. And what I was really hoping just to go through with you guys is to review the weight loss medications and use of them in type 1 diabetes, but also discuss some of the things we have to think about when we're prescribing these medications in type 1. And so what's really interesting is if you look at the timeline of how diabetes medications were developed, like way back in 1923, just our standard insulin became available. And it wasn't until the 1940s that NPH which some of you may have used at some point or may still be using, was developed, and it became commercially available in the 1960s. And then from there, we started developing some of the pill medications that we use for type 2 diabetes. And then between the 70s and 80s, we started switching from animal insulin to these human recombinant insulins. And then, things kind of stalled in terms of type 1 diabetes treatment. We just kind of tweaked the types of insulins that we had, and how long they lasted in the body. And a lot of the research really shifted to more type 2 diabetes medications. In 2005, that's when the first GLP-1, the medication that's kind of exploding in the news, came out. It was something called exenatide. Um, and you may or may not have heard this, but it was kind of co-discovered as a component of the saliva of a specific lizard. And so that's what it's kind of famous for. But then over time, development really shifted towards more of these types of class of agents. So we're really in what we call the era of GLP-1 receptor agonist therapies now. And there were some older ones that we don't really use anymore, the earlier iterations of it. But it wasn't until we got into some of these newer generations that, on top of being a good treatment for blood sugar lowering, they started to notice that people lost weight on these medications. So originally, the one that was first available was something called liraglutide, or Victoza, was marketed as a medication for type 2 diabetes. But then they did a study showing that in people without type 2 diabetes, or diabetes at all, it was actually a pretty reasonable weight loss medication. So then it was released as something called Saxenda. These are the exact same medications. One is just marketed as a weight loss medication. One is marketed as a diabetes medication. And then the one you're probably all really familiar with is Ozempic, because it's kind of exploded in its use and exploded in the media. But Ozempic is what's called semaglutide. So they basically built on this once a day medication and made it a once a week medication. The sort of base chemical is something called semaglutide. When it's for diabetes, it's Ozempic. But you may have also heard of the word Wegovy. Wegovy is the exact same medication, but it's marketed and at higher doses for weight loss. And then the newer agent on the block is one that's called tirzepatide. Tirzepatide is a combination of that GLP-1 hormone plus another gut hormone called GIP together. And the reason they were put together was the thought that it would be even better in terms of weight loss and blood sugar lowering, but that the GIP component might counteract some of the side effects that we saw with the earlier versions, which I'll talk about. So when it's a diabetes medication, you'll hear of it referred to as Mounjaro. And then more recently, its counterpart for weight loss was released in Canada, and that's called Zepbound. So the exact same medication, just different names. And because weight loss gets a premium on it, there's often cost differences between the diabetes version versus the weight loss version, with the weight loss version being more expensive. And then there are a few emerging therapies. So these are being built on, where they're taking that base GLP-1 therapy and they're mixing it with other sort of gut or glucose lowering hormones. So those will be things that are potentially available in the future, but right now they're just being studied. And why this is kind of merging with the concept of type 1 diabetes is because we're rethinking how we classify diabetes. So traditionally, somebody would be either have what we would call, like way back in the day, we would call it juvenile diabetes and adult onset diabetes. And then we realized that that's not actually the case, because I don't know if you guys knew this, but the average age of someone developing type 1 diabetes is actually 26. So it's not necessarily a juvenile disease. But we have patients who develop type 1 diabetes all the way up until their 70s and 80s. And this kind of was divided between type 1 diabetes and something we called LADA, latent autoimmune diabetes of adulthood. And they were kind of merged together with the fact that they have antibodies that cause this, versus type 2 diabetes, which was more traditionally just thought of as an insulin-resistant disease. We're shifting that now to different profiles. So what type 1 diabetes is now referred to is severe autoimmune diabetes, meaning diabetes that's caused by the immune system destroying the beta cells that make insulin. And what type 2 diabetes has been split into is something called severe insulin deficient diabetes. So people who almost have like a type 1 diabetes, but it's not autoimmune in nature. Moderate obesity related diabetes, or mild obesity related diabetes. Mild age-related diabetes, and severe insulin-resistant diabetes. And you can see here that there's a bit of an overlap between this severe autoimmune diabetes and this kind of more type 2 insulin resistant, because we are finding that type 1 diabetes is more of a spectrum, and there are patients who have a diagnosis of type 1, but just have more insulin resistance, or their body kind of acts along a spectrum, which is somewhere in between type 1 and type 2. So we're starting to think about, well, how can we use some of these medications that were traditionally developed for type 2 diabetes for type 1 diabetes? And so what's important to know is that most of these all of these GLP-1 therapies have never been done in large studies with a patient population with type 1 diabetes. So a lot of the benefits that we understand are from like very small studies where they've used these medications just to see, are they safe or are they not? Or by extrapolating what we know about them in type 2 diabetes to say, hey, maybe these could also have a benefit in type 1. And so what we know is that potentially they could help with glucose management. So for example, um, we see that some patients, when they combine their insulin with GLP-1 therapies, they might find that their insulin requirements go down, their A1C may improve, or they'll have better time in range if they're on CGM. We also know it can help with weight management, where that can be a concern in type 1 diabetes. This should not say weight management. That should say renal benefits. So we know that they can improve kidneys and reduce the risk of progressing to more chronic kidney disease. We've seen in the type 2 diabetes population where there are patients who are higher risk for cardiac events like heart attacks or strokes. It might help to lower that risk. There are some emerging studies to suggest that it reduces systemic inflammation, and that's important because other sort of joint diseases can also be autoimmune diseases and cluster together with type 1 diabetes. And what's really interesting is there was a small study that showed if we give semaglutide, which is the component of Ozempic, to people who are newly diagnosed with type 1 diabetes within the first 3 months of their diagnosis, we may be able to extend that honeymoon period they have up to 12 months. And some patients actually were able to come off of insulin when they were treated with GLP-1 therapy up to 12 months. So there's something about this medication that maybe temporarily at least halts the destruction of those beta cells, which leads to type 1 diabetes. And so how do they work? Well, we're learning more and more about this every day. There was a thought at one point, that it might help with Alzheimer's. Maybe that's not really bearing out, but where it has its major impact is on the brain. And what it does is it works in the centers of our brain that kind of promote food intake, right? Because the point of our brain promoting us to have food is for survival. But some people's brains work overdrive where they get all of this food noise, where they're constantly given signals to eat, even when they're not hungry. And what GLP-1s can do is dampen down that food noise and reduce cravings. We know in the stomach, it can slow down the emptying of the stomach so you feel more full with smaller amounts of foods. In the pancreas, at least we know with type 2 profiles of diabetes, it can help with insulin secretion. It can help with other hormones that help to lower blood sugars in a way that's independent of insulin. In the gut, again, it slows down that motility so that, again, you feel more satisfied longer. In the liver, there are some direct benefits on fatty liver disease. In the fat tissue, it kind of promotes breaking down those fat cells to use as energy, which is part of the way it helps with weight loss as well. And it promotes thermogenesis, so using our other fat cells for energy, which ends up burning more calories. And then in the heart and the kidneys, it tends to make changes in the vessels that go in those organs to help prevent either kidney failure or heart disease. So these are the effects that really more directly link to diabetes and why these medications might be more useful in type 1 diabetes. So what about the weight loss effects? So there have been different studies that have looked at this. Studies have looked at patients with type 2 diabetes and in patients with obesity or overweight who don't have diabetes. And what they found is that these agents can be really useful. So the SURPASS trial went head to head, looking at patients treated with Mounjaro and Ozempic. Where Ozempic was used to the 1 milligram dose, which is the maximum dose that's indicated for diabetes. And when they looked at the percentage of weight loss, so the amount of weight loss relative to the starting weight, interestingly, in patients with type 2 diabetes, Mounjaro on average caused about 16% weight loss from the starting weight. Ozempic in patients with diabetes at that moderate dose was about 6%. When they looked at individuals without diabetes, they found that Zepbound, so remember Zepbound is just Mounjaro's counterpart for weight loss, patients were able to lose up to 21% of their starting weight. And with Wegovy, which is the weight loss counterpart of Ozempic, at the higher doses than what we use for diabetes, patients were able to lose up to 16%. And, those numbers might not sound like a lot, but our threshold for in the past for saying a medication was successful was if someone met the 5% mark. So up until these medications came out, like our options for weight loss were pretty dismal. And then this class of medication came along and it was really helpful for people who had otherwise found it very difficult to lose weight. But what's important to also understand is that those are averages. So some people might have like a better response and lose a lot of weight, and some people might not. And that's because weight loss is different for everyone. And the reason that people gain weight and have trouble losing weight is different. So what's interesting is like in this study, they looked at the component of Ozempic and they compared it to placebo or no medication. And all these patients were given like intensive lifestyle counseling, so how to eat, how to exercise. But you can see here it's a spectrum. So some of the patients who were even on the semaglutide went on to gain weight, whereas a subset went on to lose a moderate amount of weight and some lost a lot of weight. But when you look at the placebo as well, just with the lifestyle changes and the counseling, there was a good chunk of people on these therapies who also lost substantial amounts of weight and those who also gained. And so that tells you in part that these medications are helpful, but it's not the medication alone, and certain people will have different responses. And so why is that? It's because weight gain and weight loss is a very, very complex process in our body. So part of it is some comorbidities or other medical conditions that we have, like inflammation, diabetes, PCOS, that can make it harder for people to lose weight. There's certain hormones, like some people have higher levels of ghrelin, which promotes eating, or GLP-1, which helps to satiate. It can be related to your metabolism, your microbiome. It can be like a compensation for being sick. There are a lot of behavioral and mental health aspects that go into it, as well as food access and other medications that people might be on. So in the past, people were told, oh, this is just an issue of like calories in, calories out, eat less, exercise more, it's going to balance out. That's not actually true. And if this slide looks like really complicated and overwhelming, it's because it is, but these are all of the factors that I'm thinking about when I'm talking to people about weight loss, just to show them or try to explain to them that it's not just as simple for some people as eating less and exercising more. There are a lot of things that can go sideways or be altered on these pathways that make it harder. And people who are trying to lose weight often have kind of different personalities, or what we call phenotypes. So some people who struggle to lose weight or find it easier to gain weight have what we call hungry brain. So that's these constant messages, I'm hungry, I have to eat, even if you're not physically needing food. There are some people who have what we call hungry gut, where their stomach just never feels satisfied and they feel they just have to eat and eat and eat and push in order to feel satisfied. There are people we call the slow burners, where their metabolism is just really slow. So they could basically starve themselves to, the equivalent of, a small breakfast meal, like 500 calories, and still not lose weight because their body's metabolism is quite slowed. And there's a subset of people who have more emotional eating cues. So things like stress, joy, sadness kind of promotes hunger cues. So the reality is that most people probably have an overlap of many of these different profiles. But what we've come to understand is that people who would respond better to GLP-1 therapies are people who fall into this hungry brain, hungry gut category, because that's what the medication targets. So people who have slower metabolisms, or their hunger or their weight is more driven by emotional or other environmental factors, might not have that same response to medications. And we also know across the board that patients with diabetes don't get the same weight loss response as patients without diabetes. And there are a lot of factors that probably contribute to that. So one of the big ones is diabetes medications. Oops, sorry. So in type 1 diabetes, you need insulin to survive, but insulin can promote weight gain. And a lot of people do notice when they start insulin that at least initially there could be a little bit of weight gain associated with that. We also know that other medications, medications that are used to treat like diabetic neuropathy, medications that are used to treat heart disease can promote a little bit of weight gain. We also know that some people can develop insulin resistance, and with insulin resistance, it perpetuates so that you need more and more insulin in order to lower blood sugars, and that can lead to weight gain. We also know that as blood sugar control gets better, you lose less sugar through the urine and then more sugar gets absorbed. And we also know that a lot of time our decisions with type 1 diabetes are based on avoiding hypoglycemia. So for some people, that can mean eating a little bit extra or constantly having to give kind of sugars like, poor quality, poor nutrition sugars like dextrose tabs in order to avoid a hypoglycemia. Or some people will even, fear exercising and aren't as active because of that fear of hypoglycemia. And then we also think, well, maybe there's altered receptors or how our body responds to some of these hormones or changes to the bacteria in our gut, or other medications or other things that can be leading to weight gain that make it more difficult for people with diabetes to lose weight. So when we're using these medications, the big thing that most people hear about are these horrible side effects that one of their friends had. By far, the most common side effect that comes when people start these medications are nausea. And usually it's just kind of low-grade nausea that goes away over time, like over 4 to 6 weeks. But for, in studies, anywhere between 1.5% to 7% of people found the nausea was just so bad that they had to stop. Other common ones are diarrhea and constipation. Again, like a little bit more common, maybe not as common for people to stop because of that. Vomiting can happen with initial treatment, and some people stop. People can get indigestion, they can get abdominal pain, and then they can get gallbladder disease. The sort of scary but rare ones that we often talk to people about is a condition called pancreatitis, where you get inflammation of the pancreas. We don't fully understand why some people are more at risk versus others, but it's quite painful. And if somebody does get a pancreatitis from this medication, we have to stop it. It's just not safe to continue. And if you read up on these medications, you'll see that it's associated with thyroid cancer. I want to debunk that a little bit because there's like a common type of thyroid cancer, and then there's a very rare form of thyroid cancer called medullary thyroid cancer. That it generally runs in families. So a parent would have had to have had it and passed it down to the child in order for someone to be at significant risk. So the vast majority of people who have thyroid cancer have this other form of thyroid cancer where GLP-1 therapy does not increase the risk for it. And then the big one, that we think about a little bit more in patients with type 1 diabetes is just the risk of hypoglycemia, because if you're adding an agent that either causes your food intake to be reduced or makes you more sensitive to insulin or reduces how much insulin you need, then you're going to be at higher risk of hypoglycemia when you're using that with your insulin. So those are the special considerations we have to think about when using them. So we know GLP-1 therapy in patients with established diabetes, it can be used in addition to, but it's not a replacement for insulin. Okay. And when someone is using this medication, it's really good to talk to the physician helping you, because you'll likely need an insulin dose reduction because of either lower food intake or because the medication is reducing your blood sugars. Unfortunately, these medications aren't, for people with type 1 diabetes or people with obesity, aren't covered by pharmacare. So medications like Ozempic are covered for patients with type 2 diabetes, but they're not covered for type 1 diabetes because technically that's not a Health Canada indication, but also because the government has just decided not to cover it. And third-party insurance may not cover it for type 1 diabetes either, but some third-party insurance may cover the weight loss version. So like, for example, someone with type 1 might not get Mounjaro or Ozempic coverage, but if their insurance covers weight loss medication, they might get Zepbound or Wegovy coverage. And that comes down to the last part, is that, in type 1 diabetes, these medications are considered off-label use. It's not to say that we can't use it, but if you are using this medication, it's just really important to know that we're using it for a purpose that technically it wasn't intended for. So while we know it can be safe, or it can be safe with monitoring to use these medications in patients with type 1 diabetes, technically that's not what the medication was designed for. And similarly, when people are using Ozempic for weight loss rather than a Wegovy, it's even though it's the exact same component, it's technically in the eyes of, Health Canada or a pharmacy off-label use. Okay. And then the last thing that I just wanted, I think this is the last. Yes, this is the last thing I was going to mention because I probably went way over my 10 minutes. But, you know, these medications aren't miracle medications. They can definitely help, and they can help people sort of get over whatever is making it more difficult for them to manage their weight. But the key to these medications is that it's paired with life, like healthy habits in general. So we're able exercising regularly, and that means both cardiovascular and like resistance or strength training, making sure that we're getting healthy, good quality foods to prevent side effects, making sure you're stopping when you feel full and satiated, or else you're going to sort of feel nauseous and uncomfortable. Using sort of the plate portions model that a lot of people are taught. Limiting foods that are highly processed and high in sugar, which is a concept I know that's not foreign to most people, and limiting alcohol consumption because the side effects can come out a little bit more with alcohol. So I'll pause there, Trisha. I did make a few more slides with some of the questions that were submitted, but I don't know if you want me to go through those on slides or if people want to ask the questions
I'll
live.
go ahead and ask the questions.
Okay,
If you
okay.
can, yeah, bring down the slides, that would be great.
I have slides to answer the questions. Do you want me to keep
Oh,
the slides up or because I
yeah,
think you sent
go
me a
ahead.
list. Yeah, yeah. Okay.
Sure.
Okay.
All right. So the first question is, what's really known about long-term consequences or side effects?
Yeah, yeah. So that's a really good question. So um, you know, basically when these medications were studied, they were studied up to 72 weeks, so a little bit over a year to see if there were any major upfront side effects. Um, After that, our studies looking into the long-term consequences or side effects kind of shift into what we call post-marketing reporting or retrospective studies, meaning that whenever a serious event happens with these medications, um, it's reported and then that data kind of gets added up together. Interestingly, we're not actually seeing many long-term consequences. And when I hear consequences, to me, I interpret that as like bad events. But what we're seeing more and more is benefits. So again, benefits from a cardiac perspective, benefits from like a kidney or renal perspective. That's come out more and more. Again, it's hard to say with people with type 1 diabetes because it's not studied, but we've had patients with type 2 diabetes on these medications since 2005. The big thing we always wonder about is there an increased cancer risk? And again, we're not really seeing a signal towards more cancer at this point. Um, and then the two next ones kind of blend into that where is there a risk to being on these medications long term? So again, we're not seeing any major risks. If you though go online or if you watch videos, there are smatterings of reports, about things like gastroparesis. So there are these people who have been interviewed on television shows to say medications like Ozempic caused them to have gastroparesis that didn't go away. By and large, any of those gastrointestinal side effects that I told you about generally stop when somebody stops Ozempic. So, I'm not sure what to make of these like singular cases where somebody says they got gastroparesis. Like, I don't know if that's been formally diagnosed. I don't know if that's been truly worked up. But by and large, we're not seeing that borne in our research. The last one was about can I continue Ozempic forever? For now, it seems like it is a long-term safe medication to use based on what we know.
Okay, so one thing that I hear actually from someone who has type 1 and is on Ozempic is this muscle loss,
Yeah,
significant muscle loss. And is that correct? Is that accurate?
it is accurate. So basically, it's not unique to Ozempic, though, Trisha. So any form of weight loss, any form of significant weight loss, whether it's through diet, through a medication, or through bariatric surgery, Whenever we have a method that causes us to change our hormones or change our caloric intake and we lose weight, some of that will be fat tissue and some of that will be muscle tissue. Some people are more on the spectrum where they lose more muscle versus other people, but it's not unique to the medication itself. It's a consequence of the weight loss.
Okay, and then something I also hear from women is hair loss.
Correct. And it's also a consequence. It's the weight loss. So the best way that I can and again, so whether it was extreme dieting, bariatric surgery, Ozempic, or medications like it, basically the best way I can explain it is that your body's reason of being is to keep you alive. So when somebody starts losing weight and losing weight rapidly or in a significant amount, your body thinks you're starving. Like even if from a health perspective it would be beneficial to lose weight, your body always thinks that your highest weight is the weight you're supposed to be. So whenever your body starts losing weight, it thinks, "Oh my gosh, there's a famine, we're starving." And so its first response is to shut down the non-essentials. It's a condition called telogen effluvium. It's the same thing that would happen when people get very, very sick. But basically, what happens is the body says, we're not going to focus on things like nail growth and hair growth. And it kind of pushes the hair into the phase where it falls out. Once weight stabilizes and once that rapid weight loss stops, the hair will grow back. So it's not permanent baldness, but it's more the body just shutting down things that it wants to conserve its energy for.
Okay, can I have you take down the slides just so people can see your face as
Yeah,
I
yeah, of course.
ask you more questions? So,
Sure.
Lizane in the chat box says, what do you think the timing will be for Health Canada to approve Ozempic and Mounjaro use for type 1?
So what has to happen, generally speaking, is that the drug company has to put an application for it. And bottom line is that drug companies generally only go down that route if they think it's financially feasible for them. So right now, like I don't know that there's any financial incentive for them to do it because they know patients with type 1 diabetes are buying it, they're accessing it off label. And the reality is that in the general population, the number of patients with type 1 diabetes is a lot
Mm,
lower. So
okay.
they would either have to show like some sort of life-changing research to show that, this medication is a game changer for someone with type 1 diabetes, or it would have to somehow become financially lucrative. And I think the window for that is actually narrowing because the component of Ozempic, semaglutide, is actually going to be released as a generic medication in 2026. So the company that developed it is not going to have incentive to like financially put in the money to study it or apply for it. But the bright side of that is that a medication that right now would cost $300 a month will probably come down to $75 to $100 a month. So my hope is then that maybe when the cost comes down, the government will increase like coverage or indications for it. But I don't know if that will happen.
Okay, and are there any sufficiently large studies underway that may form the basis for approval, even though
Most,
it's
yeah,
unlikely?
most of the studies that are using these component in type 1 are using it as in like at the time of diagnosis to see if these medications are viable to either stop progression of sort of like from stage like 2 to 3 or 3 to 4 diabetes. So they're studying it in like new diagnoses, but I'm not aware of any large studies that are studying it in patients who like have had long-standing or fully established type 1 diabetes. Because again, I think sort of people are taking the inference, well, if it's helpful in the kidneys or it's helpful in the heart of patients with type 2 diabetes, then why wouldn't we use it for patients with type 1 diabetes? But I'm not aware of a large scale study that's doing it right now. There might be smaller ones out there that just aren't published, but not these big ones that we see when these drugs are developed.
Okay, another question is we talked about hair loss, and you had talked about hair loss as a result of significant weight loss. But someone asked, is hair loss a known side effect where no weight loss has occurred?
If somebody is having like severe caloric deprivation, so if the Ozempic is like really shutting down their appetite to the point where they're eating very few calories, then that could lead to hair loss. But again, some people will not lose weight, even despite like significant caloric deprivation. So that could be another mechanism where it could cause hair loss without seeing that weight loss effect.
Okay. And Elaine, if you want to ask this yourself, happy to have you. But Elaine asked, can muscle loss or weight loss be minimized by micro dosing?
Not by microdosing necessarily, but the best thing that people can do when they're trying to lose weight on these medications is making sure that they're focusing on protein to get enough protein in their diet. And then we, again, like that's why we say you just don't take the medication and do nothing else. But people we know who are like proactive about doing strength training can sort of mitigate or slow down some of that muscle loss. The reality is though, like we're more and more cautious using these medications as people age and in patients who are elderly, because as we age, it's just harder and harder to build back muscle. So some people will lose some muscle as a result of these medications and find that they'll never be able to build back to where they were before, but can gain some of that muscle mass back. But microdosing has not been shown to slow down muscle loss, because again, it's not the medication itself causing the and the dose of the medication, because people can get muscle mass loss and like a lot of weight loss even on the smallest dose. Some people need the highest dose, but it's more a phenomenon of the body breaking down some of that muscle as part of the weight loss process.
Sorry, I guess my question is the goal is not for weight loss and more for managing glucose in general.
Yes.
Is there a way to avoid the extreme weight loss and the muscle loss?
Well, so not everybody will get weight loss, right? So
Okay.
the patients, when they first studied like the initial agents, so liraglutide, that was Victoza, a lot of patients who I don't like to say like normal BMI, because that's not a great way of framing things, but let's say people who didn't necessarily need like or have excess weight that they needed to lose, most of them did not lose significant amounts of weight. So if your body is at a healthy weight, you're not going to have that like 16-20% weight loss that we discussed, right? There might be like a tiny bit of weight loss, but it's not universal that everybody will have that significant weight loss. So if you're not losing as much weight or you're not losing weight in general with this medication, the risk of that muscle mass loss is much less.
Thank you.
Okay. Bernie, did you want to go ahead and ask your question? Since you're such a social guy, I figured you wouldn't mind asking yourself.
Trisha, hi, long time no see. My endo managed to get me to get pharmacare to cover my Ozempic. It's my 5th week on it,
Yeah.
but I'm open about my health. I've also had 3 heart attacks 3 years ago, but
Yeah.
since then everything's been stable.
Yeah.
I did have to try the type 2, what was it called again? You mentioned.
Metformin.
Yes.
Metformin. Yeah.
That all the side effects were from that. Like I
Yeah.
had the diarrhea and all that stuff.
Yeah.
But within a month it passed. So since I've been on Ozempic, I have lost double digits, 11,
Yeah.
11 pounds.
Yeah.
I tried the Victoza during COVID. I lost about 15 pounds, but then it flatlined, so I stopped it.
Yeah.
She's very proactive and helped me. I'm still
Yeah.
sitting at 212. I was over 225. So, and
Yeah.
I'm only 5'7". So
Yeah.
it's been helping me. Yes,
Sure.
my dependency has dropped. And I also did some limited research. It says maybe 1 or 2 years, and then I could stop it if I can control my weight gain from happening.
So I don't agree with that. So basically any form of weight loss, whether it's a medication, whether it's diet, like your body is going to plateau. The risk is that, I have a slide, Trisha. I don't know if I'm allowed to share slides again, but I'll show you
Yes,
why.
please. Yeah.
Yeah.
Share the
Okay.
slide.
Hold on. Okay. How do I do this again? Sorry. Bear with me, everyone. Oh no, I think I got kicked out of the meeting. Okay. So basically I'll try to describe this, but basically one of the studies looked at what if we stop these medications. So they put people on the medication for 20 weeks, which is when we see the first 20 weeks is when we saw the most rapid weight gain or weight loss. So we saw people went down, 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 down. And then what they did is they split up the group, and half the group continued on the medication for about like just over a year, and then the other half were given a placebo. And what they saw is that the patients who stayed on the medication continued to lose and maintain their weight loss. The patients who stopped gradually drifted back up to where they started. And the best way I can explain this is that these medications help to control the hormones and all of the signals in the body that are causing people to gain weight or maintain a higher weight. If I gave you an antibiotic for an ear infection, the antibiotic gets rid of the infection, you stop the antibiotic, and you move on with your life. Similar to insulin, right? Like if we give you insulin, the insulin is not curing your diabetes or the reason you have diabetes. It's just giving you back a hormone that you can't make at the moment. With these medications, we are not changing the underlying mechanisms, the underlying components of your physiology of your body that promote weight gain or make it harder to lose weight. We are just masking it or treating it so that weight loss is easier. So when we remove those medications, now all of those hormones, all of those aspects that were causing weight gain can just come back and surge. And the vast majority of people will regain the weight that they lost. There's always stories out there about someone who came off of Ozempic and was able to maintain their weight, but that is the minority. And not to call you out, but like you went on the Victoza, you lost the weight, but then it sounds like the weight came back, right?
No.
Or
I was
yeah,
going to say it's stable,
it's stable.
but I didn't lose enough.
Yeah.
I was also going to say I'm also guilty of not exercising, so I'm starting to pick that up as well. I haven't started yet, but I need to do more.
Yeah, but there's a lot of people who, even if they exercise, it's just like exercise for a lot of people helps to maintain the weight loss, but it doesn't necessarily like cause weight loss on its own. So the point being is that if these medications are working, it's kind of like you have to stay on them because for a lot of people, the minute you withdraw it, the weight will come back. It's not everybody, but it's the vast majority of people. And then there's kind of a subset of patients who may only get like one shot with these medications. So there have been patients who have gone on these medications, been successful or had weight loss. They come off the medication and they regain the weight. And when they go back on the medication, the body, they just don't have that weight loss response like they did the first time. So, my approach to this is like, we shouldn't be using it as like a yo-yo medication. We should be using it the proper way to try to get the most effect out of it. And then some people will reduce their dose to a lower dose to maintain their weight loss. But you run the risk that you could have weight regain if you come off of it. And it's not just the medication, right? Like some people will make and be able to maintain like significant changes to their lifestyle that helps them to maintain. But for people who are really struggling with food noise and all of these like really, really heavy messages or insatiable hunger, the minute we take away this medication, all of that comes back and it becomes very mentally exhausting to go through life constantly trying to fight the urge to eat, right? So from a mental health perspective as well, this can be like just, it'd be kind of like having ADHD. If you're constantly fighting an urge to eat, like it's hard to get on with your day and be productive. So even from like a quality of life perspective, these medications have been a game changer for people.
I agree. I agree.
Yeah.
I'm a 40-year veteran of this disease. I got
Yeah.
diagnosed at 20, and
Yeah.
I always volunteer for studies, and
Yeah.
yeah, so I'm happy it's here, and I'm happy I'm covered. Either way, I was gonna try it anyway. It's not
Yeah.
cheap. It's about 240 a month for
Yeah. It's
that.
probably you know, help is on the way in 2026 when yeah. So, you know, it's a bit of I don't know who your endocrinologist is, but it's a bit of an ethical gray line. So some people have done the metformin saying that you didn't tolerate it, and in your case, Bernie, it sounds like you really didn't tolerate it regardless. But right now they've changed the form so that we have to declare it's not just about being on the metformin. We actually have to declare that somebody has type 2 diabetes. And then the risk with that is that if we've declared to pharmacare that you have type 2 diabetes, it could impact you getting access to type 1 specific therapies down the road. So it's a bit of a, it's an individual decision whether or not. Back in the day before they changed the form, they just said, did the patient try metformin? And we didn't have to lie. We could say, yes, the patient tried metformin. We didn't have to say what type of diabetes they had.
Yeah,
Yeah,
I'm not one to risk having type 1 coverage.
yeah,
I don't think she said anything. She did say it's usually for type 2s, but
yeah.
there have been studies, and I think she's being honest. So she's been my
No,
endo
she's
for
right.
about
It's just how
20
the
years.
government views it from a coverage perspective. So I'm not denying that this is a good medication. I'm just saying from a coverage perspective, there are some gray lines sometimes with getting it covered for people, and that's one of the barriers, right? This is an expensive medication that we ask you to be on long term. So that's another huge factor that goes into starting. And diabetes, type 1 diabetes is an expensive disease to have to begin with, right?
Hmm.
I know there is some advocacy work being done at the federal government level. I don't know what's going to come of this federal healthcare plan. What we've been told is that it's probably not going to help with these medications, but there could be a chance that as coverage expands or as the medication becomes cheaper in the generic form, that maybe we'll get more coverage. And I think Lizanne mentioned manufacturer coupons. There are manufacturer coupons, but it amounts to maybe a $15 discount, which $15 is $15, but $15 out of $250 can still be quite expensive. So yeah.
By the way, Trisha knows this. I don't look at the camera because I have two screens and have a bigger screen to my left. So if you think,
Bernie, I was sitting here judging you silently. Don't worry, it's totally fine. It's totally fine. It takes a lot to offend me. Don't worry.
okay.
There's another question from Steve. Did you want to ask your question, Steve? If not, I can ask it for you.
Hi,
Okay. Go
can you
ahead.
guys hear me? Can you hear me okay?
Yes. Yeah.
Yeah, so I was diagnosed at 60. Awesome. Hey. And I found that I was putting on weight just slowly, like,
Mhm.
a pound a month or two, a pound here, another pound. I wasn't losing, I was going up. I'm very, very active. I ski, I mountain climb, I rock climb, very, very active. Um, but I was still putting on weight. So I asked my endocrinologist to put me on Ozempic, which he really didn't want to, but eventually agreed. So I've been on Ozempic about a year and a half. And I lost maybe 10 pounds, which was awesome because it took me to a really good running weight. I just felt such a change just with 10 pounds. And then I found in the last 6 months, my weight's starting to creep up again.
Mhm.
And
Yeah,
so what I've also tried to do, because I'm on 0.25, so I'm on a really low dose,
yeah.
and I don't want to go 0.5, especially with the prices. So what I've been doing is I've been going zero point 0.5 on every Sunday, and then every Thursday I've just taken 10 or 12 or 13 clicks and just given
Mhm.
myself a little microdose to
Yeah.
just see if I can maybe up it. It's
Mhm.
not working yet. So what's happening?
Like, I guess my question is, like, why are you doing the extra dose later in the week rather than just taking it all at once when you take your 0.25? Was there a
So
specific reason?
yeah, I kind of have a sense that it's kind of getting blunt
Okay,
towards the end
okay.
of the week.
Yeah, so some people truly do notice that. Um, I had a really good slide to try to tell you guys about this. So um, basically, there is a subset of patients who find that like the effect of the medication just doesn't last them the full 7 days, right? So like by day like 4 or 5, they start to notice maybe their hunger is creeping back, or maybe it's not affecting their blood sugars the way that they were hoping for. Um, and so what probably is happening there is that your body is just metabolizing the medication faster than how it was designed to last for that 7 days. So for
Right.
my patients who tell me that, so either that they are noticing the blood sugar benefit wearing off, or they're noticing like hunger starts to surge sort of more towards that end of the week if it's suppressing their hunger. Um, what I do is rather than doing something kind of similar to what you're doing, but like, for example, if the point, let's say for argument's sake, the 0.25 dose was working for you, but you were noticing that it was wearing off, then I would have them take like half of that, so 0.125, and then at day 3 or 4, take the other 0.125. And so you're
Yeah,
still
yeah.
getting the same total dose, but instead of going up and down and then having a gap and then up and down, you're kind of doing these like small little humps that starts to
Okay.
even out. So with you, like a few things could be going on, Steve. It might be that you need a slight dose increase. And it might be that you just need to do that split dosing where you're taking it, let's say, on day 1 and then day 3 or 4, just to see if
hmm
that balances out
hmm
things. Yeah.
Yeah, I definitely try that. And then you mentioned that the prices are coming down because I hear they forgot to file their patent, which was a bit silly. Um, and do you know how much they're coming down by
So
of Ozempic?
so basically the generic, so semaglutide is being explored by multiple different companies. And I'm not sure if we're going to call it a generic or sometimes when it's a hormone, we call it a biosimilar, but either way, so right now, like the base cost of one of your pens that you're using is about anywhere from 250 to $300 depending where you access
240.
it.
Yeah.
Yeah. So we think the cost of like a single pen, and I don't know how the pens are going to be designed or how long they're going to last for, or if we can like, titrate them the way we can with Ozempic with clicks. But the understanding is that the price would come down somewhere between like 75 to $100 for a month's supply if you were dialing it up the way that it's designed. These are all rumors. I'm at a diabetes conference this weekend, so I was hoping maybe some like, life-changing announcement is going to be made about the arrival of these generics. So I will let Trisha know to tell all of you guys if that is the case.
Mhm.
Originally, we were told January. But then one of the manufacturers is now saying June. So I don't know if another manufacturer is going to come in sooner, but it's sometime in 2026 that it's
Right.
anticipated. Yeah. So help is on
Yeah.
the way.
Yeah. Thanks. And one of the things is that I'm working out at the gym really hard because I don't want to lose muscle mass.
Yeah.
So I'm, doing a lot of exercise, but I'm doing specifically a lot of very heavy weights.
Good.
I
Yeah.
mean, that's relative, right? Very heavy, right? I'm not that strong,
I'm
but
sure you can lift more than I can, Steve. So go for
just to
it.
keep the muscle mass from
Yeah.
vanishing, right?
And you know what? Building lean muscle mass. So lean muscle mass actually helps with our metabolism. So above and beyond preserving muscle mass, it can help to sort of stave off that decline in metabolism we tend to get as we age. So strength training is never a bad idea, regardless of being on Ozempic or not.
It gets my appetite up though when I come from a heavy session
Yeah,
and I
that
get
can
home.
happen.
I just want to eat. It doesn't matter what if I've had a Zempic or not. I just need to eat.
Yeah,
So
yeah. So fluids and protein.
yeah,
We'll
yeah,
hopefully cut into that a
that's
little bit.
right. Yeah,
And try not to go
thank you.
low, right? Try not to go low so you're
Go low.
obligated to
Yeah,
like treat with like a fast acting sugar.
yeah,
Yeah.
yeah. Thank you.
Okay, we got 5 minutes. Does anyone want to ask a question who's on the screen? If not, I can go to a pre-submitted question. Just feel free to raise your hand. Okay, so my next question is I've had type 1 for 4.5 years, diagnosed at 37, and I'm now experiencing perimenopause symptoms with weight gain and increased insulin resistance. Could Ozempic be useful for my situation?
So potentially. So the frustrating thing about menopause is that, and this was a very famous gynecologist said this, is if you go through menopause and you change absolutely nothing in your life, you are going to gain weight. So for some women though, and again, this is just there, I don't have a study to back this up, but this is based on our conversation amongst physicians who have an interest in treat obesity, is that potentially the combination of a medication like Ozempic plus menopausal hormone therapy, if it's indicated or safe for you, can help to blunt some of that weight gain. But some women will just naturally gain quite a bit of weight in menopause. So I'm not saying that it will completely stop the process, but it might help to sort of blunt or sort of I guess lessen the impact of menopause. And as much as it's no fun and no one wants to gain weight in menopause, gaining a little bit of weight in menopause is actually protective because we know women who gain a little bit of weight in menopause are less likely to have osteoporotic fractures. That being said, I don't want to gain weight in menopause either. So I hear you. I hear you.
Okay,
Yeah.
great. Next is please speak about microdosing. Specifically, I take 0.25 milligrams once weekly, then 10 clicks 4 days later to prop up the fading
I wonder
That's
if
effect.
that
me.
was Steve.
That
That's
was
Yeah, I
you?
me.
think that
Oh,
That
was
was
that was
Steve
me.
you.
mentioned.
Oh,
Yeah,
sorry.
that
Yeah.
was me. That was
So
me.
I think, Steve, I agree. There are some people who would do better with splitting their dose and taking it twice a week. So I don't think there's a benefit in terms of the medication effect to like following a microdosing schedule, but having a more steady state of the medication in the body, if you're metabolizing it more rapidly, definitely could help. Yeah.
Okay. What is the
Dr.
real
Tang,
risk
sorry.
of?
If
Oh,
I
sorry.
may
Go ahead.
interrupt, Stephanie just has her hand up.
Yeah, go ahead, Stephanie. Sorry.
Oh, it's all good. Can you hear me?
Yes. Hi, Stephanie.
Okay. Hi. Okay, great. Thanks. So you answered the question that I had that I had submitted to Trisha about there is a lipolytic effect in taking it, that it actually does burn fat. So that's great because that partially answered my question. So I'm just curious, like I tend to promote like body building as a
Yep.
means of body composition
Yep.
changes.
Yep.
So is that medication something that could be safe to, or like more effective to use in a cutting phase? So if you're building, you're either at calorie neutral or calorie
Yeah.
surplus, so that you're actively working to build lean mass, say over like a 4 to 6 month period. And then you're already in a cutting phase and you're changing. Now you're going deliberately into caloric restriction or caloric reduction,
Yeah.
specifically to try to lose body fat. Now, people who bodybuild who don't have type 1 are aware that you are losing some lean mass.
Yeah.
But
Yeah.
because you spent that time deliberately building it first, your rate of loss ideally is less. And so I'm just curious, like, is it something that can be cycled in the same way that you would cycle your nutrients or your program?
Like, I wouldn't recommend cycling it just because of this concept of tachyphylaxis, or the possibility that you'll stop responding. So the complicated thing about hormones is, so in order for, sorry, I just got an Uber notification for some reason that blocked your face, Stephanie. The weird thing about hormones is it's part of it is like, how much hormone is your body making or receiving externally? And then how is your body receiving it by way of receptors? If the concern, or what we're concerned about, because this is a phenomenon that can happen with other hormones, is if your body is in a constant state, now I have high levels, now I have low levels, now I have high levels, now I have low levels. The body doesn't like that up and down. So the risk could be that the body basically down regulates or takes away some of those receptors because it doesn't like the up and down. So then if you start using the medication again, you're not going to have the receptors to actually make it effective. Whether or not it's a useful agent in cutting, like, I don't really follow like the bodybuilding world as well. But I would think the risk of using it in a cutting phase is like, you're kind of like 2 steps forward with your muscle gain and 1 step back. And I think, if caloric deprivation to cut is causing some muscle mass loss already, if you add on the Ozempic and you get even more even more weight loss with it, then the risk is that you'll get more muscle mass loss. But I can't really say it's been systematically studied for this purpose.
Okay.
Okay.
No, I appreciate that.
I don't
Thank you.
know.
Yeah.
I can't say it's safe. I can't say it would work. You might feel sick doing it, the up and down, depending on how long your cycles are.
Sure.
Yeah. But hey, let me know what your experience is, and maybe that will, experiences.
As soon as you said down regulate receptors, I was like, oh, that sounds too dangerous to me. It actually sounds safer to take.
It just means that the medication, it could be less and less effective each time you use it. Yeah. Well,
I mean, and that happens as you reduce your overall body mass too, though, right?
Yeah.
So yeah.
Exactly.
Okay. No, thanks for that, Jordanna. I appreciate that.
No worries. Hopefully I didn't make it more confusing for you, or
no, not at all.
Okay, it looks like it's 7 o'clock, and I know Dr. Kapeluto is at a conference in Toronto, so we're going to wrap it up. I want to thank Dr. Kapeluto for being our guest speaker and teaching us everything about GLP-1s and all the similar medications.
You know what? You guys came with a lot of good questions and a lot of knowledge already. So I don't know how much I taught you, but thanks for having the conversation. And again, like, I don't think it's wrong to use it, but you always want to do it under the supervision of your endocrinologist or whoever's helping you with your diabetes, because at the end of the day, it can be a safe medication to use if it's done safely. And the last thing we want is for people to be hiding its use and getting into trouble with it. So.
All right. Well, thank you, Dr. Kapeluto.
No,
and if you have any other topics you want us to have on the huddle, just feel free to email me.
All right.
Thank
if I can think of
Thanks,
anything.
everyone. Bye-bye.
Bye.